Welcome to the most important topic in upper limb, the brachial plexus. If you read through this topic thoroughly, right, you can confidently sit in your exams. It will boost your marks, whether it is your theory, practical, your university exams, or even your competitive exams. Upper limb is all about nerve injuries and it's all about brachial plexus. Okay, there are a lot of MCQs, 5 marks, clinical scenarios around it. So let's dive into it. A 4-week-old baby was brought to the pediatrics OPD for a routine checkup. On examination, it was observed that the baby's left arm was medially rotated, adducted, and the left forearm was pronated and extended. Where is the site of lesion? So if you follow this, right, next few minutes, if you're with me, you'll be able to figure out this case scenario. And the brachial plexus as such is an important topic. Why is it important to know about the brachial plexus? What does it do? It is a plexus of nerves. Plexus, it's a network of nerves, right? So we have the cervical plexus, we have the brachial plexus, lumbar plexus, sacral plexus. All the plexus that you see in the body, remember, it is going to be formed by the ventral rami of spinal nerves. And the brachial plexus is contributed by the ventral rami of C5, C6, C7, C8 and T1. What is it going to do? It is going to supply the upper limb. What do I mean by that? This brachial plexus, okay, it has motor fibers that supplies the muscles of upper limb. It has sensory fibers that supplies the skin of the upper lip. Also, it has the sympathetic fibers. The sympathetic fibers in the brachial plexus, they supply the blood vessels in the skin, right? Blood vessels of the upper lip. They supply the sweat glands and the erector pylorum muscles of the skin, right? So you got an idea. What is brachial plexus? What is the function of brachial plexus? Now we should know what are the components of the brachial plexus, what are the branches, what are the structures it's going to be supplied, what are the conditions these nerves can get injured, and what deformity the patient will present with. It is really very easy if you understand. Okay, so I need your attention for the next few minutes. Components of the brachial plexus. In this picture, you can see that the nerves are shown in like different colors, right? 1, 2, 3, 4, 5. So there are 5 components for the brachial plexus. Okay, it has the roots. The roots, okay, they unite to form the trunks of the brachial plexus. Roots is nothing but the ventral rami of C5, C6, C7, C8 and T1. There are 3 trunks, upper trunk, middle trunk and lower trunk. Each trunk will divide into 2 divisions, anterior divisions and posterior divisions. I'm just going with the basics, okay, so that you'll be able to understand and apply it. Anterior division and posterior division. What do you mean by anterior division? The branches which come from the nerves contributed by the anterior division, they'll supply the anterior aspect of your upper limb, anterior aspect of the arm, forearm, all that. Similarly, the branches coming by the nerves contributed by the posterior division will supply the posterior aspect of the upper limb, posterior aspect of arm, posterior aspect of the forearm, the muscles and the skin. Okay, and the divisions, they unite to form the cords. There are 3 cords for the brachial plexus. What are they? We have the lateral cord, the medial cord and the posterior cord. The cords are named in relation to the second part of the axillary artery, which means that the lateral cord, it lies lateral to the second part of axillary artery. Medial cord lies medial to the second part of axillary artery, and the posterior cord will lie posterior to the second part of axillary artery. Okay. Now these cords, they further divide into branches. So these are the components of the brachial plexus. We have the roots uniting to form the trunk. The trunk is dividing, then they're uniting to form the cords and branches, right? Where are they located? It is important to know the location because some pathology in that area could be the reason for nerve injured in that area. Okay. For example, the roots and the trunks, you can see it's over the neck. But which part of the neck? Behind the sternocleidomastoid and in front of trapezius, we have the posterior triangle of neck. The root and the trunks, they are found in the posterior triangle of neck. Why am I telling this? Because any procedures over the posterior triangle of the neck can accidentally injure the roots or the trunks of the brachial plexus there. Okay, and coming to the divisions occur exactly beneath the clavicle. The cords and the branches, okay, they are seen in the axilla. So this part of the brachial plexus which you see above the clavicle, that is the root, the trunk and the divisions can be together called as the supraclavicular part of brachial plexus. And the branches that arise from the root and the trunk, they are called as the supraclavicular branches. In an MCQ or in your short note, you can name the supraclavicular branches of brachial plexus, or which one of them is a branch coming from the supraclavicular part of brachial plexus. The branches from the root and the trunk. Whereas the branches that come from the cord, okay, this part is called as the infraclavicular part of brachial plexus. Now, moving on to the relations of brachial plexus, as I told you, the root and the trunk, they are found in the posterior triangle of the neck, right? So in that area, we have the scaleni muscles. The trunks of the brachial plexus are seen to emerge between scalenus anterior and scalenus medius muscle. Okay, and then we have the cords that are seen in relation to the second part of axillary artery. Formation of the brachial plexus is very important. So let's do it together. As I told you, the roots, right? Ventral rami of C5, C6, C7, C8 and T1. Sometimes there can be a contribution from C4. In that case, it will be called prefix brachial plexus. A contribution from the T2 will be called postfix brachial plexus. The C5 and C6 ventral rami, they unite to form the upper trunk of brachial plexus. C7 will continue solo as the middle trunk of brachial plexus. C8 and T1 will unite to form the lower trunk of brachial plexus. Now, each trunk is going to divide into anterior division, which I am showing you in blue color, and a posterior division, which I am showing in green color. So these are the divisions. All the greens, okay, the posterior divisions of all the trunk, they unite to form the posterior cord of brachial plexus, which lies posterior to the second part of axillary artery. The anterior division of the lower trunk will continue as medial cord of brachial plexus. So what is left now? The anterior division of the upper trunk and the middle trunk, they unite to form the lateral cord of brachial plexus. So this is a schematic representation of the formation of brachial plexus. Understood? Coming to the branches. So we divided from the components, right, which is supraclavicular part and which is infraclavicular part. Okay, so you see the root, the trunk and the divisions, the supraclavicular part. So any branches coming from the root or the trunk is called as the supraclavicular branches. And please remember, there are no branches from the divisions of brachial plexus, right? From the root, we have the long thoracic nerve, ventral rami of C5, C6 and C7. C5, C6 and C7, they unite to form the long thoracic nerve. Ventral rami of C5 alone, okay, it will give rise to the dorsal scapular nerve. Okay, and there's one more branch from the ventral rami of C5, the accessory branch to phrenic nerve, C5. And the scaleni muscles, the muscles in the neck, they are also supplied by the ventral rami, okay, coming from C5, C6, okay. And we know that the long thoracic nerve, it innervates which muscle? Serratus anterior, which causes protraction of scapula. Injury to the long thoracic nerve in the posterior triangle or during mastectomy procedures, which is found on the medial wall of the axilla, right, can lead to winging of scapula. Dorsal scapular nerve, it supplies three muscles. What are they? Levator scapulae and the rhomboids minor and major. Accessory branch of phrenic nerve, it joins the phrenic nerve to supply the diaphragm. And one more important point, over the upper trunk. How is the upper trunk formed? C5, C6 unite to form the upper trunk. That is going to divide into anterior division and posterior division. From the upper trunk, there are two branches, suprascapular nerve and the nerve to subclavius. What are the muscles innervated by the suprascapular nerve? Supraspinatus and the infraspinatus. Remember, the action of supraspinatus that initiates your abduction, 0 to 15 degree. Infraspinatus, lateral rotation of the arm. Nerve to subclavius, it supplies the subclavius muscle. This point on the upper trunk, which is the junction of 5 nerves, C5, C6, okay. The suprascapular nerve, nerve to subclavius, anterior division and posterior division is called as the Erb's point, okay. So, injury to the upper trunk at this point will cause Erb's palsy, which we'll be discussing shortly. So, that's about the supraclavicular branches of brachial plexus. Now, going to the infraclavicular branches of the brachial plexus, which means the branches that come from the three cords, the lateral cord, medial cord and the posterior cord. How was the posterior cord formed? The union of the posterior division of all the rami, right? C5, C6, C7, C8 and T1. So, ultra, okay, using this mnemonic, you can remember the branches of the brachial plexus coming from posterior cord. Upper and lower subscapular nerve, thoracodorsal nerve, radial nerve is the largest branch of brachial plexus, which carries all the root values C5, C6, C7, C8 and T1, and branches coming from the radial nerve, it supplies the posterior aspect of the arm and the forearm, the skin over the entire dorsal aspect of the upper limb. Then we have the axillary nerve. The axillary nerve with the root value C5, C6, it innervates two muscles. What are they? Deltoid and teres minor. It gives one cutaneous branch that supplies the upper lateral aspect of the arm. We'll be talking about it in detail, another topic, okay? Thoracodorsal nerve is the only one. It's easy to remember, okay? You cannot confuse it with anything else because there's nothing similar. The thoracodorsal nerve is the only one with the root value C6, C7 and C8. It innervates latissimus dorsi, the swimmer's muscle, the muscle which elevates the trunk during climbing, well developed in monkeys, right? The lower subscapular nerve, it innervates teres major that inserts into the medial lip of the bicipital groove. The upper and the lower subscapular nerve, they innervate the subscapularis muscle that inserts into the lesser tubercle medially placed, causing medial rotation of the humerus. Okay, so the root value for this is also C5 and C6, the upper and lower subscapular nerve. So that is about the posterior cord of brachial plexus. Moving on to the branches coming from the medial cord. M, M, M and U. Easy. Medial cord is formed by, yes, continuation of the anterior division of the lower trunk with the root values C8 and T1. So all the branches will be having C8 and T1. Medial root of median nerve that joins with the lateral root of median nerve to form the median nerve. And then we have the medial pectoral nerve, which innervates, yes, pectoralis minor, it pierces, right, innervates it, and also the overlying pectoralis major. And then medial cutaneous nerve of arm, which joins with the ventral rami of T2, right, forming the intercostobrachial nerve, supplying the posteromedial aspect of the arm axilla. Medial cutaneous nerve of forearm that lies between the axillary artery and axillary vein. And lastly, but most important, the ulnar nerve. The ulnar nerve has the root value C7, C8 and T1. That 7 I have enclosed within brackets because these fibers are borrowed from the median nerve because of the communication that exists between the median nerve and ulnar nerve in the forearm. So that's about the branches of medial cord. Easy? Moving on to the branches coming from the lateral cord, even more easy, right? The lateral root of median nerve, musculocutaneous nerve, and the lateral pectoral nerve. So the lateral root of the median nerve joins with the medial root of median nerve to form the median nerve. Musculocutaneous nerve, yes, we have seen. Lateral cord is formed by the anterior division of upper trunk, middle trunk, right? So with the root value C5, C6, yeah, and C7. So the musculocutaneous nerve, it innervates the muscles in the front of arm. What are they? Coracobrachialis, biceps, and brachialis. After supplying these three muscles, it continues as we saw in that case scenario, right? Lateral cutaneous nerve of forearm. The lateral pectoral nerve, it pierces the clavipectoral fascia to supply the pectoralis major muscle. Is that fine? So in your spotter, it is very, very important to identify the nerves if pinned, and there are certain landmarks where that will be a clue for the identification of these nerves, okay? So we'll do it. Coming here, this one which pierces the coracobrachialis muscle, yes, that is the musculocutaneous nerve. So this is the landmark, okay, piercing the coracobrachialis, and just posterior to it, going horizontally, going to wind around the surgical neck of humerus. This one here, yes, that will be the axillary nerve winding around the surgical neck of the humerus. So that is the one going horizontally, right? And this one here formed by the union of two roots, the medial root and the lateral root here. This is our median nerve. Okay. This one here, yeah, this and this, supplying the subscapularis muscle will be the upper and lower subscapular nerve. Okay, the upper and the lower subscapular nerve. This important nerve which is seen to run along the anterior surface of the serratus anterior muscle is the long thoracic nerve. The nerve of Bell or the nerve to serratus anterior. Okay. Now, this one, I'll take the arrow little lateral and put it here. Yes, this is the latissimus dorsi muscle. This nerve which is seen to supply this latissimus dorsi is nothing but the thoracodorsal nerve. This one piercing the pectoralis minor. This is the pectoralis minor muscle. Piercing it, medial pectoral nerve. And this one, you can see it innervating the pectoralis major is the lateral pectoral nerve. Okay. So these are the important ones that you should be able to identify in your spotter or in an image-based question. So you can identify the axillary artery here. You can make out the axillary vein here, right? And this is the pectoralis minor dividing the course of the axillary artery into three parts. And I told you the lateral cord, medial cord and posterior cord are named in relation to the second part of axillary artery. Okay. So again, you can make out the musculocutaneous nerve in this picture, right? You can identify the median nerve is easy to identify, formed by the two roots, isn't it? And this picture, you can easily make out the axillary nerve, right? It is going to wind around the surgical neck of posterior aspect of the surgical neck of the humerus. Coming to the injuries related to brachial plexus. So what is that you appreciate here? Yes, whenever there is something happening between that can stretch this part, the angle between the neck and the shoulder, that injures the upper trunk of the brachial plexus at Erb's point, leading to Erb's palsy. Also, during normal vaginal delivery, when you're trying to pull the babies out through the vaginal canal, the stretching of this part between the neck and the shoulder can injure the upper trunk of brachial plexus. So all this can be given as a case scenario from which you have to pick out the cues. So the injury to the upper trunk of the brachial plexus at the Erb's point can lead to Erb's palsy. What is this Erb's palsy? Okay. So the attitude of the upper limb is typical. As you see here, this injury to the upper trunk, the arm is kept closer to the body, right? What do you call it? It's called as adduction. The arm is adducted because the abductors are paralyzed. The nerves that supply the abductors are injured. And it is also internally rotated, medially rotated. The elbow, you can tell me, looking into the picture, is it bent or straight? It is extended, right? The elbow is extended because the nerve that supplies the flexors of the elbow are injured. And the forearm is pronated, right? This is the classical feature. It's called the policeman's tip deformity, the waiter's tip deformity. I'll repeat it again. The arm is adducted, medially rotated. Elbow is extended, forearm is pronated, right? So what is it due to? As I told you, it is kept adducted because the abductors are paralyzed. What are the abductors of the arm? Yes, you can tell me. The supraspinatus is the one that initiates abduction, right? And up to 90 degree, it's by the deltoid. Arm is kept medially rotated because the lateral rotators, yes, the infraspinatus and teres minor that inserts into the greater tubercle of the humerus are paralyzed. Flexors of the elbow are biceps and brachialis are the powerful flexors of the elbow, right? They are also paralyzed. Supinator, biceps is a supinator and one extensor muscle of the forearm, the supinator. They cause supination of the forearm, right? Now coming to the what are the nerves? You can tell me. Supraspinatus is innervated by suprascapular nerve that also innervates the infraspinatus. Deltoid is innervated by axillary nerve that also innervates the teres minor. The biceps, brachialis, coracobrachialis, all of them are innervated by the musculocutaneous nerve. Supinator is innervated by the radial nerve. Okay, so what are the nerves involved here? Yeah, it is the musculocutaneous nerve, axillary nerve. Okay, and one point, do you remember Erb's point? What are the two branches coming? Suprascapular nerve and nerve to subclavius. Also the radial nerve. These are the nerves injured in Erb's palsy. Lower trunk injury, which is also called the Klumpke's palsy, occur when this part is stretched. The part between the upper trunk and the arm, right? The lower trunk is stretched in those type of injuries, leading to Klumpke's palsy. In Klumpke's palsy, the patient typically presents with clawing. This is called clawing, okay? Clawing of the digits, clawing of hand. The muscle which is responsible for clawing is lumbricals. I'll tell you what the lumbricals will do. So this is your metacarpophalangeal joint. These are your interphalangeal joint. The action of the lumbricals, okay, it is to flex the metacarpophalangeal joint and extend the interphalangeal joint like this. There are 4 lumbricals for the 4 digits. The reversal of this is what is happening at the metacarpophalangeal joint. It is straightened now. Here it was bent, now it is straightened. What happened to the interphalangeal joint, which is straight, are now flexed. Okay, so lumbricals will cause metacarpophalangeal joint flexion and interphalangeal joint are extended by the lumbricals. This is reversed. It leads to clawing. Okay, how many lumbricals I told you? There are 4 lumbricals. Okay, the first, second, third and fourth. The first and the second are innervated by median nerve. The third and fourth are innervated by ulnar nerve. Okay, so in Klumpke's palsy, the nerves which are injured are the median nerve and ulnar nerve. They not only supply the lumbrical, they supply so many intrinsic muscles of the hand. So lower trunk injury, Klumpke's palsy affects the intrinsic muscles of the hand, which are innervated by median nerve and ulnar nerve. So the clawing is typically seen, but apart from that, the signs and deformity related to median nerve and ulnar nerve injury also can be seen in the patient. Okay, another important thing, lower trunk is formed by C8 and T1. The T1 right nerve, they carry the sympathetic fibers, yeah, coming from the cervical ganglion, which are going to innervate the part of the face. And involvement of this sympathetic fibers leads to something called as the Horner's syndrome due to the involvement of the sympathetic fibers. So here, this is the right and this is the left, right? So appreciate the size of the pupil in both the eyes. Which one is smaller, constricted? This one. This constriction of pupil is called miosis. The sympathetic fibers, they innervate the dilator pupillae, which are responsible for dilating the pupil. If the sympathetic fibers are injured, there's no dilatation, it goes for constriction called miosis. Anhidrosis. Yes, the sympathetic fibers, they supply the sweat glands and responsible for secretion of the sweat, right? So the opposite of that, no sweat secretion, anhidrosis. N of thalamus. Okay, the eyeball looks small and shrunken. And then laws of ciliospinal reflex. These are the features of Horner syndrome, which is seen as a part of injury to the lower trunk of brachial plexus. Again, we have done this. So this is the left and this is the right. Which one is abnormal? Yes. The medial border and the inferior angle, they stands prominent. It's called winging of scapula. The nerve injured is long thoracic nerve. What is the muscle paralyzed? Serratus anterior, which is supposed to protract your scapula, is paralyzed. So the retractors are working hard and these retractors are attached to the medial border of the scapula, making it look more prominent. Another applied anatomy of brachial plexus is that apart from the nerve injuries, we have different types of anesthesia, right? General anesthesia and local anesthesia. If you want to perform some surgery in the upper limb, okay, you can, what you want to make, like you have to keep the patient free from pain. So you can inject the anesthetic fluid around the branches or the cords or the trunks of the brachial plexus. This is called as brachial plexus block. Yes, we have learned in detail everything about brachial plexus. 360-degree concept about the brachial plexus. What are the parts? Where is it located? What are the branches? Supraclavicular, infraclavicular. From each cord, what branches? What is the root value? What are the structures applied by each branches? And the nerve injuries related to brachial plexus. Shall we do some questions now? Come on, give the answers. The trunks of the brachial plexus are located in, not in the axilla. Beneath the clavicle, we have the divisions, not in the anterior triangle. The roots and the trunks are situated in the posterior triangle. You can see it emerging between scalenus medius and scalenus anterior muscle. Which of the following is a branch from the supraclavicular part of the brachial plexus? Now, the median nerve, axillary nerve is from the posterior cord, thoracodorsal nerve is from the posterior cord, long thoracic nerve with the root value C5, C6 and C7, it comes from the roots of the brachial plexus. All the following are branches from the posterior cord except the upper subscapular nerve, lower subscapular nerve and the radial nerve. The ulnar nerve with the root value C7, C8 and T1, it comes from the medial cord of the brachial plexus. Very good. Root value of thoracodorsal nerve C6, C7 and C8. A baby boy was delivered in a tertiary care center after a difficult labor following forceps delivery. 4 weeks later, the baby was brought to the pediatrics OPD for routine checkup. On examination, it was observed that the baby's left arm, these are the cues you have to pick up, right? It was medially rotated, adducted, left arm pronated and extended. So this typically describes the deformity seen in Erb's palsy. Now, what is the question? Where is the site of lesion? At Erb's point in the upper trunk of brachial plexus. All the following nerves are involved in Erb's paralysis except, of course, suprascapular nerve, which supplies supraspinatus and infraspinatus. Axillary nerve supplies deltoid and teres minor. Musculocutaneous nerve supplies coracobrachialis, biceps and brachialis. The median nerve and ulnar nerve are involved in Klumpke's and not Erb's palsy. A 4-month-old infant was brought to pediatrics OPD with complete paralysis of digital flexors and intrinsic muscles resulting in claw deformity. Okay, there was also Horner syndrome. The mother told that the baby was delivered by an emergency caesarean section due to failure of normal vaginal delivery. Which of the following statement is incorrect? The injury involves lower trunk of brachial plexus, of course. Entering Horner syndrome, it is Klumpke's palsy. The intrinsic muscles of hand are paralyzed, yes. Sympathetic fibers are injured, yes. Median nerve and ulnar nerve are involved and not the radial nerve. Radial nerve doesn't supply any intrinsic muscles of the hand. Is that okay? The nerve arising from the pointed structure, it supplies all the following muscles except. So this session we started with this image. Do you remember I told you there are 5 different colors demonstrating the 5 different components of the brachial plexus. So what is it? It's very easy. You can see that all the, like this purple is contributed by 3 divisions. Posterior division of all the 3 trunk, it is the posterior cord that is pointed out in this image. Now coming to the question. All the muscles, the nerve arising from the pointed structure supplies all the following muscles except. Subscapularis is supplied by upper and lower subscapular nerve coming from the posterior cord. They want except. Triceps is supplied by radial nerve that's coming from the posterior cord. Deltoid is supplied by axillary nerve that comes from the posterior cord. Coracobrachialis is supplied by musculocutaneous nerve that comes from the lateral cord of brachial plexus. So shall we circle this? Okay guys, hope this session was useful. It is very important. Okay, so definitely if you're thorough with this topic, you can boost your marks high up. Thank you.